Welcome to today's pharmacology quiz on SNRIs, part of our ongoing quiz series. In this video, we'll test your understanding of serotonin, norepinephrine reuptake inhibitors, medications commonly used to manage depression, anxiety disorders, and neuropathic pain. The quiz features 10 multiple-choice, scenario-based questions designed to challenge your clinical reasoning. Each question includes 5 options, followed by the correct answer and a concise explanation. There's also a companion video that offers a full teaching review of SNRIs. The link is provided in the description below. So, let's get right into it. Question 1. Mrs. Hughes, a 55-year-old woman, is receiving pharmacological management for fibromyalgia. Her physician prescribes an SNRI known to alleviate chronic musculoskeletal pain. She later reports constipation and dry mouth. Which of the following agents is most likely responsible for both analgesic and antidepressant effects in this patient? Option A, milnacipran. Option B, venlafaxine. Option C, flaxetin. Option D, sertraline. Option E, bupropion. The correct answer is option A, milnacipran. The explanation is that milnacipran is a serotonin norepinephrine reuptake inhibitor, SNRI, specifically approved for the management of fibromyalgia, where it provides both analgesic and antidepressant benefits. It enhances descending inhibitory pain pathways by increasing serotonin and norepinephrine levels in the spinal cord. Common side effects include constipation, dry mouth, and increased heart rate due to its noradrenergic activity. The other listed drugs are either SSRIs or non-SNRI antidepressants, and thus are less effective in chronic musculoskeletal pain management. Question 2. Mr. Lawson, a 56-year-old man with type 2 diabetes mellitus, complains of neuropathic pain and depressive symptoms. His physician initiates treatment with an SNRI that improves both mood and pain perception. Which of the following drugs is most appropriate for this patient? Option A, duloxetine. Option B, flaxetin. Option C, amitriptyline. Option D, sertraline. Option E, venlafaxine. The correct answer is option A, duloxetine. The explanation is that duloxetine is an SNRI commonly prescribed for major depressive disorder and diabetic peripheral neuropathic pain. It increases both serotonin and norepinephrine concentrations in the central nervous system, improving mood and modulating pain transmission. Its dual action makes it ideal for patients with diabetes who experience neuropathic discomfort alongside depression. The other antidepressants listed are less effective for neuropathic pain, with tricyclics like amitriptyline being alternatives but less favored due to side effects in older or diabetic patients. Question 3. Mr. Hughes, aged 70, has chronic neuropathic pain secondary to diabetes mellitus. His doctor prescribes desvenlafaxine. 2 weeks later, he experiences hypertension, insomnia, and tremors. Which of the following statements regarding adverse effects of SNRIs is not correct? Option A, can increase blood pressure due to noradrenergic effects. Option B, may cause serotonin syndrome when combined with MAOIs. Option C, commonly cause weight gain and sedation. Option D, may lead to hyponatremia in the elderly. Option E, can cause sexual dysfunction similar to SSRIs. The correct answer is option C, commonly cause weight gain and sedation. The explanation is that SNRIs do not typically cause weight gain or sedation. In fact, they may produce insomnia, agitation, or mild weight loss due to noradrenergic stimulation. Their pharmacological profile often results in increased alertness and elevated blood pressure rather than sedation. While side effects such as hyponatremia, serotonin syndrome, and sexual dysfunction can occur, weight gain and sedation are more associated with tricyclic antidepressants and some atypical antidepressants, not SNRIs. Question 4. Mrs. Henderson, 33 years old, presents with postpartum depression. She is currently breastfeeding and asks if her new medication, venlafaxine, is safe during lactation. Her physician discusses potential risks and benefits. Which of the following statements is most accurate regarding SNRI use during breastfeeding? Option A, venlafaxine is excreted into breast milk and may cause infant irritability. Option B, duloxetine is contraindicated because it is not secreted in milk. Option C, desvenlafaxine is the safest SNRI in lactating women. Option D, SNRIs have no effects on infants through milk exposure. Option E, breastfeeding should always be discontinued during SNRI therapy. The correct answer is option A, venlafaxine is excreted into breast milk and may cause infant irritability. The explanation is that venlafaxine and its active metabolite, desvenlafaxine, are excreted in breast milk, potentially leading to irritability, poor feeding, or mild withdrawal symptoms in infants. However, the clinical significance of these effects is generally low, and many clinicians consider it acceptable with close monitoring. The benefits of continued maternal mental health treatment often outweigh these mild risks. Statements suggesting absolute safety or mandatory breastfeeding cessation are inaccurate and overly restrictive. Question 5. Mr. Carpenter, aged 55, has major depressive disorder and benign prostatic hyperplasia, BPH. His doctor considers an SNRI but is concerned about worsening urinary retention. Which of the following SNRIs is least likely to aggravate his urological symptoms? Option A, duloxetine. Option B, venlafaxine. Option C, desvenlafaxine. Option D, milnacipran. Option E, levomilnacipran. The correct answer is option B, venlafaxine. The explanation is that venlafaxine exhibits relatively lower noradrenergic activity compared to agents like milnacipran or levomilnacipran, making it less likely to cause urinary retention. Drugs with strong noradrenergic effects can tighten the bladder sphincter and exacerbate lower urinary tract symptoms in patients with BPH. Therefore, venlafaxine is often preferred in men with prostate enlargement who require antidepressant therapy. In contrast, duloxetine and levomilnacipran are more prone to worsen urinary hesitancy due to greater norepinephrine reuptake inhibition. Question 6. Mr. Hughes, aged 60, with chronic pain, is treated with an SNRI. His clinician is considering switching to another class for better tolerability. Which of the following antidepressants belongs to a different class but shares dual serotonin, norepinephrine modulation? Option A, amitriptyline. Option B, venlafaxine. Option C, duloxetine. Option D, desvenlafaxine. Option E, levomilnacipran. The correct answer is option A, amitriptyline. The explanation is that amitriptyline is a tricyclic antidepressant, TCA, which belongs to a different chemical class than SNRIs but still inhibits both serotonin and norepinephrine reuptake. This dual action allows it to provide antidepressant and analgesic benefits, similar to SNRIs. However, TCAs generally have a less favorable side effect profile, including anticholinergic effects like dry mouth and constipation. Other options listed are all SNRIs and therefore do not represent a different class. Question 7. Mr. Ellis, 41, has been taking duloxetine for 6 months to manage diabetic neuropathic pain. His renal function is declining with an eGFR of 32 milliliters per minute. Which of the following statements about dosage adjustment and elimination of SNRIs is most accurate? Option A, duloxetine should be discontinued due to reduced renal clearance. Option B, venlafaxine should be increased to offset reduced excretion. Option C, desvenlafaxine is contraindicated in mild renal impairment. Option D, milnacipran does not require dose adjustment in renal dysfunction. Option E, duloxetine is primarily excreted unchanged in urine. The correct answer is option A, duloxetine should be discontinued due to reduced renal clearance. The explanation is that duloxetine is extensively metabolized in the liver and its metabolites are partly excreted in the urine. In patients with significant renal impairment, eGFR less than 30 ml per minute, accumulation can occur, increasing the risk of toxicity, including nausea, somnolence, and hepatotoxicity. Therefore, discontinuation or avoidance is recommended. Other SNRIs, such as milnacipran or desvenlafaxine, may require dose adjustments, but duloxetine is specifically not advised in severe renal dysfunction. Question 8. Mrs. Grayson, aged 67, with recurrent depression, reports dizziness, orthostatic hypertension, and falls after switching from citalopram to duloxetine. Her doctor considers switching her back to an SSRI. Which of the following statements best differentiates SNRIs from SSRIs in terms of clinical and pharmacological properties? Option A, SNRIs produce fewer withdrawal symptoms. Option B, SSRIs are more effective for neuropathic pain than SNRIs. Option C, SNRIs cause less hypertension than SSRIs. Option D, SSRIs have stronger noradrenergic effects. Option E, SNRIs inhibit norepinephrine reuptake in addition to serotonin. The correct answer is option E, SNRIs inhibit norepinephrine reuptake in addition to serotonin. The explanation is that SNRIs target both serotonin and norepinephrine transporters, while SSRIs primarily inhibit serotonin reuptake. The noradrenergic activity of SNRIs contributes to side effects such as increased blood pressure, dizziness, or insomnia. This dual mechanism also enhances their efficacy in neuropathic pain and fibromyalgia. SSRIs, in contrast, are generally less effective for pain and do not exhibit significant noradrenergic effects. Question 9. Mr. Lawson, aged 52, has major depressive disorder poorly controlled by venlafaxine. His psychiatrist considers augmentation therapy. Which of the following drugs, if combined with an SNRI, would most increase the risk of serotonin syndrome? Option A, linezolid. Option B, bupropion. Option C, mirtazapine. Option D, haloperidol. Option E, lorazepam. The correct answer is option A, linezolid. The explanation is that linezolid is a reversible monoamine oxidase inhibitor used as an antibiotic, and combining it with SNRIs can dramatically increase serotonin levels, precipitating serotonin syndrome. Symptoms may include hyperthermia, tremors, agitation, and autonomic instability, which can be life-threatening. Other options such as bupropion, mirtazapine, haloperidol, and lorazepam have minimal serotonergic activity and pose a lower risk when combined with SNRIs. Careful monitoring is essential when high-risk combinations are considered. Question 10. Mrs. Miller, aged 61, has generalized anxiety disorder and osteoarthritis. She is prescribed duloxetine for dual therapeutic benefit. All of the following statements regarding duloxetine are true except one. Identify the incorrect statement. Option A, it is metabolized primarily by CYP1A2 and CYP2D6. Option B, it can be used for chronic musculoskeletal pain. Option C, it has a shorter half-life than venlafaxine. Option D, it may cause liver toxicity in predisposed patients. Option E, it is contraindicated in patients with severe hepatic impairment. The correct answer is option C, it has a shorter half-life than venlafaxine. The explanation is that duloxetine actually has a longer half-life than venlafaxine, averaging around 12 hours compared to venlafaxine's 5 hours. This allows for once or twice daily dosing with sustained effects. Duloxetine is metabolized by CYP1A2 and CYP2D6, can treat chronic musculoskeletal pain, and poses hepatotoxicity risk, especially in patients with pre-existing liver disease. It is contraindicated in severe hepatic impairment, making all other statements correct. Conclusion. That wraps up our revision on SNRIs, an essential topic in pharmacology that bridges the understanding of antidepressant therapy and clinical application. I hope this quiz has helped reinforce your grasp of their mechanisms, therapeutic uses, and clinical considerations. For deeper study, I highly recommend consulting Katzand and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF, for up-to-date clinical guidance. These resources provide comprehensive explanations and evidence-based recommendations that complement what we've covered here.